And so I'd really like to present on the topic today of retroperitoneal sarcomas and talk about what a challenge this is. And this is work really that I've started to work on with my group in Toronto, but this historically has been done by many of my senior colleagues. So I just wanted to start off for people who may not be familiar with this tumor to think about getting a CAT scan like this in your clinic. So this is a 45-year-old man. The classic story is got a CT scan for kidney stones, and you find this massive tumor in the retroperitoneum. So what next step would you do? Would you, if it looks technically resectable, take the patient to the operating room and explore? Would you get a biopsy of this tumor? Would you send them forward for radiation therapy, or would you discuss this with your medical oncology colleague? So I have three goals for my session. First is to define the management principles of retroperitoneal sarcoma. Secondly, to talk about the role of neoadjuvant treatment in this disease. And finally, in the last part, to talk about the challenges of local recurrence in this tumor. When should we retreat patients? So as that initial CAT scan showed you, these are often very large tumors and the patients are asymptomatic. There can be a broad differential diagnosis for these masses, and what's really important to highlight to the patients is that this is a non-urgent scenario. You do need time to work through their problem. We certainly would stress the need to feel that you have to do a diagnostic laparotomy in these patients, and it does take careful planning for complete resection of these tumors. So what's the differential diagnosis of a retroperitoneal mass? Well, obviously we're focused on sarcoma today, but when these patients show up in your clinic, depending on what the imaging features, may suggest other diagnoses like lymphoma. I probably diagnose at least 2 or 3 a month in my clinic. Germ cell or testicular cancers in younger men, a true renal cell cancer, neuroendocrine lesions, or other benign sarcomas of the retroperitoneum. Common diagnostic misadventures that we see in our sarcoma group are patients who've been operated on somewhere for an atypical hernia, often inguinal, it could be umbilical, and it's just the fact that no preoperative imaging triggered the fact that this was actually an underlying cancer. Obviously quite rare, but can happen. The other thing is this dilemma of whether it truly is a renal cell cancer, so your urologic colleagues may ask you for help. And finally, the fact that a complex retroperitoneal mass is down in the pelvis, so the initial assessment is usually with the gynecologist and only has an ultrasound. So how do we diagnose these retroperitoneal masses and how do we manage the patients? Well, I would stress again in our discussions of imaging that CT is really the workhorse of what we do. This gives us a very good image of chest metastasis, for example, which is uncommon in this tumor but can happen, and also gives us a good roadmap for surgical resection. Our preference is to do MRI for extremities, and I think this is true for all sarcoma centers. And for abdominal wall tumors, we do an MRI as well. And I'm a Canadian, so the government actually won't pay for PET scans in these patients because the evidence is very limited that this actually shows any benefit. We can get it on specific releases, but I think it just goes to say that the evidence doesn't support that PET scans are required to try to understand these patients. So if there is a diagnostic dilemma, if it's not a classic liposarcoma like I just showed you, you may need to go ahead and get a biopsy done prior to managing the patient. And obviously knowing exactly what the tumor type is going to drive the treatment. So what features do you want to assess prior to doing the biopsy on the imaging? You want to see how heterogeneous the tumor is. I'm going to show you an example of that. Does it look like it has both high and low-grade components? Does it invade into fascial planes? Sometimes these tumors go down into the adductor canal. And also you want to assess the involvement of adjacent critical structures, such as the aorta and the IVC, or any other nerve involvement that you need to discuss with the patient. So this is a slide I've borrowed from Dr. Brennan. This is really just to highlight, as we've talked about today, what heterogeneity exists in sarcoma. And there is a difference between, as other people have shown today, what subtypes occur in the retroperitoneum versus the extremity. So again, liposarcoma is by far and away the most common in the retroperitoneum. And the second most common one is leiomyosarcoma, which is distinguished from the most common subtypes in extremities. So this is a patient of mine that I managed almost 2 years ago now. And when I put the CT scan up is really to discuss the concepts of assessing on preoperative imaging, both the extent, so this is a large retroperitoneal sarcoma, which really encompasses the left hemi-abdomen, and also some of the tumor features. So in this liposarcoma, this fatty tissue, you can see an island of tumor here, which is really high grade. And that's important for surgeons to be able to understand. Also, the converse is true. It's important to appreciate that this well-differentiated liposarcoma also needs to be resected. And we often see patients resected in other places where this is removed, but there's a failure to recognize that there's well-differentiated liposarcoma that needs to be removed. So one of the challenges by far for retroperitoneal sarcomas is the fact that the predominant means of failure or inability to cure patients is local recurrence. So this is historical data from our institution, but any other sarcoma site could also produce this data. And what this really shows is the dismal long-term outcome for the retroperitoneal sarcoma patients in comparison to extremity that does much better, and also the truncal lesions, where there is a plateau with longer-term follow-up. And one of the big challenges in treating these patients is that they continue to have local recurrence and failure quite a long time out from their initial resection and diagnosis. So getting back to the topic of multidisciplinary management of retroperitoneal sarcomas, the real keys here are first and foremost that good surgical resection is the mainstay of treating these patients. And this is the best way to try to cure them of their disease in localized, potentially resectable tumors. One of the big challenges, though, as you saw the scope of some of those tumors I've shown you before, is because of their size, there's the inability to try to get a good margin in many critical areas. And so the margin negative rate, or the R0 rate, is really throughout the literature about 50 to 90%, which is quite a broad range over time. And so along with that, the 5-year survival rate, the overall survival rate is about 50 to 65% from most of the sarcoma centers reported worldwide. And this is associated with a local relapse-free survival of 40 to 80%. So this really begs the continued question of how do we do better? How do we improve survival rates? And how do we provide better local control in trying to understand the biology of this disease? So one question always as surgeons is more surgery better than less surgery? And several groups have published in the past few years about doing a more aggressive surgical operation to try to improve outcome. And this, I would say, is controversial data because many sites often have been reporting more recent surgical multivisceral resections with historical data. And again, the challenge is based on the biology of this disease and the fact if the follow-up is much longer in this earlier cohort, we don't really know what the local recurrence rates are long-term in this particular series. However, I would say that our group does try to do fairly aggressive resections, and this is really data from my senior partner, Carol Swallow, where you can see that in these larger resections, the posterior margin of taking muscles like psoas and iliacus is almost performed in the majority of patients. A colectomy is usually required. A nephrectomy may be critical, especially when the vascular pedicle to the kidney is involved and it is an at-risk margin. There are times where we have to do a chest wall or a diaphragmatic resection to get a margin negative resection. And then along with that, further surgical planning may involve resection of other organs such as the liver, the pancreas, a total gastrectomy, a splenectomy, and or duodenal resection. So again, going back to the literature, trying to show you how do people handle these tumors, is more surgery better? There's a combination paper that was published in 2010 from both the French and the Italian group. And Alessandro Granci is certainly someone who is a very enthusiastic advocate for taking even partially involved organs in this particular approach. And so I think this paper shows us some things of benefit to note as surgeons, but again, I'm not sure if this retrospective series really can answer this question for us. So what you can see from their literature summary here is, again, the range of complete resection over time in primary only retroperitoneal sarcoma goes from about 50% up to almost 100% in this series. The 5-year overall survival rate is still not as good as we would like it to be. It ranges from about 50% up to 65% in this series. And again, the big struggle is with the local recurrence relapse survival, which ranges from about 40 to 80%. So what price do the patients pay by undergoing a more aggressive resection? And here they actually did a nice data analysis. There's fairly limited data about complications associated with this type of surgery. And what they showed that with increasing number of organs being resected, that the patients required more reoperations. 12% is fairly high for a surgical series. And also that there was a perioperative death rate of about 3%. They also analyzed how did this correlate with the type of organ that was resected. And in this series of four plots, what you can see is that venous resection, arterial resection, and reconstruction, duodenectomy or a Whipple or a total gastrectomy really place the patients at much higher risk of having significant surgical morbidity. So as you plan these operations, some of the points to really consider are first and foremost to really image the patients and get a good roadmap of what's there and decide before you go into the operating room what you really have to take out. I would say the key structures that we neurose about, everybody should neurose about, is whether or not the duodenum is really involved, because adding a Whipple in the middle of a 12-hour operation that's unplanned is really not advantageous for the patient. Looking at major vascular involvement is something that's very critical, and also thinking about contralateral kidney function is essential in trying to manage these patients. At the end of the day, the fundamental issue of tumor biology and looking at neoadjuvant chemo or radiation therapy is something that is always integrated into managing these patients, and I'm going to talk about that in a minute or two. But I think having a thorough discussion with the patient is also very important. We tell our patients they're all going to have a major complication. It's a question of which one they're going to get. I'm certainly fortunate to have a colleague who is able to participate in these cases with us as necessary. And as you can see with some of the larger tumors, there may be critical steps as a surgeon that you should achieve sooner rather than later to avoid prolonged futile dissection and to be unable to resect the tumor. So there certainly is a movement in this rare tumor population that surgeons who handle these cases on a regular basis should probably be the only people doing them. So really focusing on, besides surgery, what are other neoadjuvant strategies that can be used? And this is a very challenging arena because there's really not a lot of evidence for retroperitoneal sarcomas. Again, it comes back to the themes that this is a rare disease. It's difficult to do randomized controlled trials. I'm going to talk a little bit about some of the clinical data that we have. But outside of extremity data, which David summarized quite nicely for radiation therapy, it's quite limited for retroperitoneal sarcomas as they are less frequent. And again, we struggle with this late presentation or patients that are really quite sizable tumors by the time we start to plan their care. So the fundamental question we always talk about when we see these new patients in clinic is when should we consider adding chemotherapy or radiation to our patients' care? So Dr. Mackey certainly talked a lot today about chemotherapy, and I'm glad to say I'm not in conflict with him because overall we would say there's no proven benefit for the widespread use of adjuvant chemotherapy for sarcoma. It's really unfortunate. It can be beneficial for large tumors, breast tumors, we're starting to use it more systematically in pancreas cancer. But the toxicity of the agents that are currently available limits its use in patients. There are certain scenarios where a sarcoma group should really think about treating these patients preoperatively, and that would be with tumors like Ewing's sarcoma, rhabdomyosarcoma, and PNETs. Those tumors have a higher rate of metastasis, and they are very chemosensitive. The other group where we often consider chemotherapy in are patients that are truly borderline resectable. And our practice is to give it consecutive with radiation therapy. We give the chemotherapy first. We re-image the patients after 2 cycles of usually doxorubicin and high-dose ifosfamide. If there's good response, we keep going. If there isn't, we may switch to radiation therapy because we're also cognizant of losing a therapeutic window of being able to operate on the patients. So it's important to reassess that. And again, as Dr. Mackey emphasized, the current lines of chemotherapy offered in soft tissue sarcoma are true for retroperitoneal lesions, and this consists of doxorubicin, which is limited by significant cardiac toxicity, and higher dose ifosfamide. On certain occasions, based on patients' performance factors, our medical oncologists will give gemcitabine and taxotere in leiomyosarcoma, which can actually be quite beneficial. So here's a recent case that's been managed in our sarcoma site group, and Dr. Swallow was the surgeon that looked after this patient. And this is a 45-year-old mechanic who presented with this massive intra-abdominal tumor. And a biopsy was done and confirmed that this was a high-grade leiomyosarcoma, so a relatively chemosensitive subtype. And you can see the tumor's almost encasement of the central arterial structures, as well as of its intimate involvement with the inferior vena cava. And after assessing the patient and talking about it, our group decided to give him preoperative chemotherapy. He was then given external beam radiation, and he subsequently went to surgery. So here you can see the significant response of chemoradiation prior to surgery in these CT scans. And here on the axial images are some more details about proximity to the duodenum and concerns about involvement of the SMA, making this clearly a borderline resectable tumor. And the response that this patient actually did quite well with neoadjuvant therapy, and certainly took a period of time for the patient to get through this therapeutic regime. So the surgical resection in this particular case was done by both a surgical oncologist and a hepatobiliary surgeon. The patient had a laparotomy and had a right nephrectomy, a right hemicolectomy, a cholecystectomy. We tend to always take the gallbladder out in a radiated field because it's a very necrotic structure and you don't want to have to reoperate. He also had a duodenectomy with a Roux-en-Y reconstruction. And our HPB colleague did a partial IVC resection with a native reconstruction. So this patient actually did amazingly well through all of this treatment. He went home on the 9th day and was just admitted with a small bowel obstruction several days later. So when we again think about this tumor, the nature of retroperitoneal sarcomas, if the real problem is local control, how can we make this better? And although we would agree that surgery is the mainstay of treatment in retroperitoneal sarcomas, it's quite obvious from that slide that I showed you earlier on that the overall survival in this site is much worse than other sites of soft tissue sarcoma. We do have randomized controlled trials, again, what David Kirsch showed today, that, and Dr. Brennan, that adjuvant radiation therapy does improve local control, but it wasn't associated with improved survival. But again, extremity sarcomas are different because there is a higher rate of distant failure. So the rationale of trying to compare this apple and that orange in soft tissue sarcoma isn't quite the same. And certainly our group has been quite interested in thinking much more about local recurrence, as it is the primary site of failure in retroperitoneal sarcomas. And I think that generates 3 questions. The first is really a technical question. Can radiation therapy be delivered safely to tumors with such a large volume? There are not a lot of sites that really have the skill of radiation oncologists that can do this. The fundamental question of does radiation therapy even impact on local recurrence in this disease, or could this translate into overall survival in retroperitoneal sarcoma? And then the third question, again, always comes back to timing of neoadjuvant or adjuvant treatments. Should this radiation therapy be given pre-op or post-op? So I'm going to start with the third question, and certainly you can imagine that giving radiation therapy to a well-defined target volume like this preoperative tumor is much easier than trying to anticipate where the tumor was in a post-operative setting. And even though we're a fairly proactive, cohesive group in Canada where I practice, we still see a lot of patients sent to us for the discussion of post-operative chemotherapy. So this is a slide I've borrowed from Dr. Rout's paper, and this just nicely highlights again the principles of why you would think about preoperative delivery if you're going to radiate a patient in the preoperative setting. So again, like I showed you, the gross tumor volume is more clearly demarcated for radiation planning. The radiosensitive viscera, in this case the small bowel, are clearly displaced by the tumor itself, so that's a benefit of keeping the tumor in situ. It allows you to look at the biological efficacy of radiation in the preoperative setting. A higher dose can be achieved because of fewer surgical adhesions, and that's really what the radiation oncologists struggle with in the postoperative setting. And again, the tumor's treated in situ prior to actually violating the tissue planes during surgery. So this is a slide that my colleague Charles Catton has shared with me, and I'm not sure if I can explain all of the details here, but what you can see is in their complex conformal planning, and we use more advanced radiation techniques at Princess Margaret in Toronto, you can see that the radiation oncologist has mapped out the tumor itself. Then there's the additional margin of trying to obtain a sterilized field around the tumor. Critical structures that they think about protecting always in these patients is the spinal cord itself, and sometimes that limits their ability to give radiation depending on where the tumor is, and also protecting contralateral kidney function. And just with normal patient respiration, that's why the field for the kidney planning is actually different from what you see on the CT. So what I'd like to do is share with you some of the data that exists, and this is again from our center, in trying to answer the question of does radiation have any benefit in retroperitoneal sarcomas. And so this is a phase 2 study that was published several years ago, again led by Dr. Swallow. And in this study, which accrued patients for 4 years, 83 patients with retroperitoneal sarcoma were considered for preoperative radiation and plus or minus randomized to brachytherapy and surgery. And it's interesting to note that the postoperative the brachytherapy is really put into this protocol because the standard at that time was that patients with extremity sarcoma got preoperative external beam, and postoperatively they got a boost. So this is the postoperative boost, was the concept of adding brachytherapy into the trial. The treatment schema was to give them external beam radiation for 5 weeks at a dose of 45 to 50 gray and 25 fractions, wait 6 to 8 weeks, and then perform their surgical resection. The surgeon decided at the time where the at-risk margins were, and certainly for right-sided tumors, this was often near the duodenum. They waited for at least 5 days before performing brachytherapy, and this was, if applied to the patient's care, was pulsed to a maximum total dose of 70 gray. Now, I'm not going to present all the data from this today, but it's important to note that the brachytherapy was actually quite toxic, and we learned from this trial not to overtreat patients. And there actually were 2 deaths associated with brachytherapy treatment, so we've learned that that's not a beneficial thing to do in this disease. And so this is a complex slide, but it really just goes to show you these were the 83 patients that were enrolled in the trial. There were 7 patients who actually did not move forward through the treatment algorithm. And prior to actually having surgery, there were several patients who either developed distant metastasis after radiation before their surgery, so they were not included in the analysis. And there were 4 patients who had preoperative deaths. And in talking to our group, I think that one of the things we learned about this trial is that the inclusion criteria was too broad. And what I'm going to present to you is the data on the final 40 patients that made it through the whole treatment protocol. And so 19 of those received brachytherapy and 21 of them did not. So of the total 55 patients included in the analysis, what I just want to highlight is that, again, the majority of them had liposarcomas, 2/3 of them had high-grade tumors, and 2/3 of them had primary tumors, although recurrent tumors were also included in the analysis. So if we look at the overall survival, and this is longer-term follow-up of this cohort of 40 patients in this phase 2 trial, what you can see here is that the 5-year overall survival for these retroperitoneal sarcoma patients was 75%, which is actually quite good, and their 10-year survival is 63%. And compared to our historical controls, where there are a lot of variables that differ between this trial, including radiation and also different surgeons, you can see that this was an improvement. If we look at the subgroup analysis here, differing between brachytherapy or not, you can see the brachytherapy patients did worse. Although this was not statistically significant, I think the curves are impressive. And if we actually look at the next series of patients, so this is one of the challenges in this smaller group of patients. This is not on protocol, but as our group continued to follow those 40 patients along with the next cohort of patients treated by preoperative radiation and surgery, what you can see is that with a median follow-up of 5 years, that the 5-year overall survival for this cohort is 87%, which is actually quite good. If we do the subgroup analysis looking at high versus low-grade tumors, you can see here's biology again. The low-grade tumors, 5-year overall survival is 96%, whereas with the high-grade tumors, their 5-year overall survival is 75%. If we now look at this parameter of recurrence, if we look at recurrence-free survival in this cohort of 50 patients, the 5-year recurrence-free survival in our group is 74%. And this, again, differs significantly with our historical controls at our institution. And when you break this down by subgroup, looking at low-grade versus high-grade patients, you can see again that the 5-year recurrence-free survival of 91% is excellent in retroperitoneal sarcomas. And this, again, was statistically significant. So one of the challenges when you do a phase 2 trial, I think we learned a lot about toxicity. We learned a lot about how to treat these patients. This was a nidus to try to do a randomized controlled trial as being the gold standard in surgical care. And unfortunately, although a trial was designed and launched through ACOSOG, for various reasons, comparing surgery versus preoperative radiation plus surgery, this trial failed. It just did not accrue enough patients. So we're really left trying to make conclusions with suboptimal data. But at the end of the day, you have patients to treat, and you really have to try to learn the best you can from what's happened. So what would we say about preoperative radiation therapy in retroperitoneal sarcoma? Well, again, there's no randomized controlled trial for this group. I've presented you with the data, slightly edited from our group, showing a longer-term follow-up in 50 patients in total. I think it's reasonable to say there's relatively low toxicity in treating these higher-grade tumors, and the significant toxicity due to brachytherapy was well illustrated from this trial and is really not used at our site at all. Overall, we can say that there's excellent survival compared to historical controls, but this is likely multifactorial, and we can't attribute it to radiation alone. But we have learned to select better patients. Our initial inclusion of 83 patients, we really realized only a proportion of those could even get through the trial. And certainly more aggressive surgery is what our group has implemented. So our current management at our program is to consider all patients with high-grade, deep, large tumors for preoperative radiation therapy. But even then, we have an active discussion as to who gets radiation and who does not. So when do you operate for recurrent disease? This is quite a challenging topic, and I could spend an hour talking about this as well. But just to really say that since local recurrence is the primary failure in these patients, this is a common problem you're faced with. And you're also often faced with dealing with persistent disease when somebody else operated on the patient and left tumor behind. And this is an exhaustive list of things that we really try to think about as we try to decide whether or not to operate on these patients. Again, it comes back to a slide Dr. Brennan actually showed about extremity sarcoma. Looking at the biology and the latency between previous surgery and recurrence is important. Multifocal disease overall is usually not favorable to reoperate on patients for. I think it's very important to talk to the patient and understand that there's a limited chance of cure. You now need to discuss what needs to go in addition to previous multivisceral resections. You may have to reoperate in a previous radiation field, which is not easy. We certainly try to avoid fixing any ventral hernias in patients with retroperitoneal sarcomas because it limits the chance of return, and that has been an interesting component of my practice. And finally, I think this always just comes down to clinical judgment. There really is limited literature on this. So again, local control in retroperitoneal sarcoma, this is data from Dr. Lewis and Dr. Brennan, and this just highlights that complete resection is associated with disease-specific survival. And this is another slide that I really think is very instructive to those of us that look after these patients, that the percent of complete resection is inversely proportional to the number of operations. And I think both Dr. Swall and myself always hear this line from Dr. Brennan in our head saying the last operation should have been your final one. So just to close, surgical and adjuvant therapy of retroperitoneal sarcomas, the principles to practice are to minimize exploratory procedures and avoid open biopsy. It definitely takes a multidisciplinary team to manage these patients, along with expert pathology review, which I haven't really mentioned. We do consider preoperative radiation therapy in all of our patients, but we definitely limit it for younger patients and with low-grade disease. Chemotherapy is primarily added in for patients who have borderline tumors. I would agree with the concept of resecting en bloc with expendable viscera and structures. I think it's important to follow these patients closely and for their lifetime because they continue to fail many years out. And finally, as we teach our fellows, do it right the first time, and that's something that's very inherent in managing these patients. So I'd just like to close by acknowledging members of our multidisciplinary group in Toronto, which is a fantastic place to work. And the only name that's missing from this slide is Dr. Brennan, who I have to say for me really ignited my passion of looking after sarcoma patients. And I think he's taught many of us that there's so much more to do than what we've done before. So I'm very much looking forward to hearing about selective targets because I think that's the next phase of what we have to do to improve patient care. Thank you.